Hey, Emma, thank you so much for having me back with Zomedica. And wow, what a great crowd we have tonight, guys. Thanks for spending a Wednesday evening. I think it's Wednesday. I've had a busy two last weeks, and I just touched down in Cabo San Lucas, Mexico, about 2 hours ago, and lecturing to you here from the Mexican Baja, California, where we're going to have a seminar the next couple of days. So, let's see, as Emma said, I got to get my screen set for you guys. There we go. Emma said, again, I'm a diplomat of the American College of Veterinary Internal Medicine. Spent most of my career in private practice in the Tampa Bay area. Do some adjunct faculty work currently at Colorado State. And from a financial standpoint, again, obviously this is sponsored by Zomedica, so I am a consultant for them as well as Hills and PRN PharmaCal. Really difficult for me to show you this slide that shows that Zomedica is located in Ann Arbor, Michigan. That just hurts to say it. As you can see, I'm an Ohio State graduate from both undergrad and vet school, and losing to Michigan last weekend was a difficult thing. Okay, well, guys, we're here to talk tonight a little bit about Cushing's disease and Addison's disease, really focusing on diagnostic testing, since these are two diseases that are not uncommon to be seen in private primary practices, and kind of see if we can walk through the way we've traditionally gone ahead and try to make diagnoses of these two disorders, and then maybe a little bit more about what's available to you guys currently in regards to considering endogenous ACTH, which is something that up until recently you really couldn't quantitate or measure very easily in private practice. So let's start with some normal things. Let's just take a quick look at the hypothalamic pituitary adrenal axis, or the HPA axis, and how it works. Obviously, an understanding of this is important in diagnosing these disorders. So like any other endocrine system, it's a negative feedback loop. So it starts in the brain with the hypothalamus secreting corticotropin releasing hormone. That acts upon the anterior portion of the pituitary gland to secrete adrenocorticotropic hormone, or ACTH. It'll be a big important player of what we talk about this evening. And that ACTH, of course, will then stimulate the adrenal glands in the abdomen to produce primarily cortisol. ACTH stimulates a very small amount of aldosterone and sex hormones. But again, for tonight's talk, our interest is going to be on how it affects cortisol levels. Of course, again, a negative feedback, meaning that blood cortisol can be sensed then back at the hypothalamic region and the anterior pituitary gland, so that we can turn things off when it's not necessary. So bottom line is, if you need to make cortisol, you go through this system. If you have enough cortisol in the system, it'll regulate back to the brain and slow things down until you again need to make it. So very well regulated, tightly controlled. We recognize in companion animal medicine and that we've got, again, some disorders of the adrenal glands. And we can either have an excess production of cortisol and hyperadrenocorticism, or Cushing's disease. We also certainly see an insufficiency of cortisol production, again, hypoadrenocorticism, or Addison's disease. And we'll briefly talk about both of those this evening. When you go back and you look, I graduated in 1987 and had the pleasure of, I believe, one of my mentors is on tonight's phone from my internship. But we go back to the late 80s, and the tests that we use to diagnose Cushing's disease and Addison's disease have always focused really on either stimulating or suppressing cortisol production. And those tests in veterinary medicine were actually described very early in my career, for sure. You go back, this is the initial class of in the 1970s of the American College of Veterinary Internal Medicine. And these guys and one gal were the ones that probably should hold this sign that said, hey, we invented the ACTH stim test and the low-dose DEX suppression, because they did. They're the ones that published on it. And basically, we still use those tests today. An amazing picture. I know so many of the people on there that were instrumental in my career. And man, look at some of the dress going on in this picture. Nice pants right here. Why do we have this gentleman in the back? Look at that coat. Probably because he's wearing those same pair of pants. That would be bad to put him up front. Over here, the California boys looks like they're going to go serve dinner as a waiter when this picture was taken. All right, so let's talk specifically then about both diseases. Let's start with Cushing's disease. And still probably the most current major reference for the diagnosis of Cushing's still is almost, well, actually over 10 years of age now. 2012, good friend Dr. Ellen Barrett co-chaired this consensus statement from ACVIM that talks about the tests. And we really still use this pretty much verbatim in many ways today. But it certainly helps us get a plan for how we diagnose patients that, obviously look Cushingoid in these pictures. So as a practitioner, I'm in the same boat you guys is. I haven't been back in the universities until just recently. I've been in clinical practice seeing patients day in, day out. So for me, when I get a referral case or a patient that comes in through the clinic and I suspect they might have Cushing's disease, the first things that I want to know is two questions. Do they have the disease? And the first thing I'll say, and they make a big emphasis to you in this paper, is that when you're looking at endocrine disorders, really the patients you should be testing and where you're going to have the most clear-cut results and not get confused are the ones that actually have the disease and have the common features of that disease. Common things occur commonly. So you should be testing patients that have clinical symptoms, PUPD, polyphagia, panting, weight gain, large liver, abdominal distension from the weakening of those abdominal ventral muscles, muscle weakness potentially across the body. Those are the classic things we think of. And then, of course, we add in the dermatologic signs, endocrine alopecia, where we see, again, truncal alopecia like you see in this, what I think is a Sheltie. The face certainly looks like a Sheltie. The rest of the body looks like a Cushingoid beast. That real thin skin, that hyperpigmentation, even comedones. We want to test patients that have the majority of those common or major signs. Laboratory changes should include things like elevations in liver enzymes, especially alkaline phosphatase, high lipid levels in the bloodstream, cholesterol, triglyceride. They may have some changes in CBC, like a neutrophilic leukocytosis, neutrophilia and monocytosis, maybe a slight increase in red blood cells. But again, you're going to have the most success when you actually test patients that have these diseases or these signs. If you simply took a dog who came into your clinic today with a looked normal, didn't have any clinical complaints, had an ALP of 8,000, and didn't have anything else going on this list, the likelihood of that dog having Cushing's disease as an explanation for its one laboratory finding wouldn't be very high. And that's not a patient that I would prioritize this sort of testing in. So, but basically, let's test patients that have the common clinical and laboratory signs. This guy here could be Cushingoid, not as striking as the last guy you saw. But again, as we start to get away from these common signs is when oftentimes test results are less clear. So the second thing I want to know is if I do find that a patient has Cushing's disease, what's causing it? We know that in veterinary medicine, we can have two basic forms, common forms of Cushing's disease. There's others, but these are the two most common, either pituitary dependent, or what we used to call PDH, which is usually a microadenoma, small area of tumor within the pituitary gland. I've designated this angry yellow emoji as my pituitary tumor. This would obviously be a macroadenoma because of its size. But again, these are tumors in the brain that are going to be secreting ACTH as the cause of our Cushing's. So we have a new term that maybe makes more sense nowadays. We're going to call this form ACTH dependent Cushing's disease. And that's in contrast to the other form that we see commonly, or less commonly would be better said, the old name adrenal dependent. And again, this either happens from a benign, an adenoma, or a malignant adenocarcinoma involving generally one, although rarely we can see both glands involved. And for our talk today, we're going to make this purple devil emoji our adrenal tumors. And again, they secrete cortisol, leading to the clinical signs of Cushing's disease. So again, we're going to call this a little differently nowadays, the term ACTH independent, because again, this is a tumor that's directly secreting cortisol. ACTH has no bearing, so it's independent in this sort of a case. So that's the new terminology that's out there now. So let's talk about screening. So you have a patient that has some of these common clinical signs, and again, maybe has some of these laboratory findings that are common with Cushing's disease. How are we going to screen them? How are we going to make this diagnosis? Well, you've got several tests you could consider. I wouldn't consider this. Just running a random cortisol is not likely to produce results that can clarify the situation for you. We know what the normal reference range for cortisol in the bloodstream is, but whether you are a patient who's normal, whether you're a patient that has some illness not related to your adrenal glands, so we'll call it non-adrenal illness, or whether you are Cushingnoid, there's wide fluctuations that occur throughout the day. And depending on when you took this blood sample, you may or may not find results that would be consistent with what you're thinking is going on. So bottom line is, random serum cortisol level by itself would never be recommended or is not a good screening test to define Cushing's disease. There's just our tumors popping in. So what about urine? Could we use urine as a screening test for Cushing's disease, looking at urine cortisol values? And again, we're going to index those to creatinine, so the urine cortisol to creatinine ratio. Generally recommended, if we do this, we want to try to collect it when a patient is not excited, is not having any driving force for making cortisol. So usually it's first thing in the morning, after a good night's sleep, before a patient gets up and gets active, would be the time to collect this urine at home. Sometimes, this is a picture from Ohio State, where a student actually told us she was unable to collect urine from her dog at home because every time she put a bowl underneath the dog's back end, it ran away. So the clinician I was on duty with, who will remain nameless, but he was in that original picture I showed you, he says, why don't you duct tape a bowl to your dog's perineum? And this student took him literally. She went home and did that, and lo and behold, it actually works. Now, I'm not stressing that this is a point of today's lecture that you should start doing this, but it's just a humorous anecdote. So again, what about collecting urine cortisol? Bottom line is, this should be reflective of, again, collecting it when there's reduced activity and stress, and using that, the indexing the creatinine will negate the effect of urine volume on the test. However, it's not a good test for diagnosing hyperadrenocorticism. It has a sensitivity that we used to find was close to 100%. So in sensitivity, we would basically say that no dog with Cushing's disease should ever have a normal urine cortisol creatinine ratio. So if you got normal, it would rule the disease out. That's the high sensitivity. More recent papers suggest that the true sensitivity might actually be 75 to 80%, meaning there's a fair number, maybe up to a quarter of your cases, that are Cushingnoid dogs that will test normal on this test. So again, not a good screening test to either rule in or rule this disease out. So those don't help us. So we've got to do something proactively to try to evaluate this system. So over the years, we've either tried to stimulate or suppress cortisol production. You guys are certainly aware of the ACTH stimulation test. We give synthetic ACTH intravenously to the body. And if you're a normal patient, it'll stimulate your adrenal glands, the cortical release of cortisol, but to a normal range or to a normal point. You'll generally see cortisols stimulate less than 20 micrograms per DL in a normal dog. If you can put a tumor, you have Cushing's disease in here, that adrenal gland, if it's an adrenal, if it's a pituitary dependent or ACTH dependent case, will stimulate that adrenal gland to grow, the cortex region, the zona fasciculata. And when we hit that with synthetic ACTH, we're going to over-release cortisol. We've got an exaggerated amount of cortisol reserve, which is what Cushing's dogs have. So we're generally going to be over 20 micrograms per DL. And if you put a tumor in that adrenal cortex that's secreting cortisol, the combination of that secretion plus stimulation from ACTH will again create a situation where your post-ACTH stim an hour later will be above 20 micrograms per DL. Is it a good test? It's got some moderate, depending on the study, sensitivity and specificity issues. So no test is perfect in this realm. It cannot distinguish between tumors of the brain or in the adrenal gland itself. It's expensive. ACTH synthetic cortrosine is expensive. It's not always easy to get. Many times general practitioners don't carry it in their clinics. And again, you still have to collect multiple cortisol samples to send to a lab. So let me talk about the sensitivity and specificity that for me I don't know about you guys out there tonight, especially at 7 p.m. Eastern Standard Time. I hate statistics. I mean, I know I have to know them as an internist, but I try to simplify them for what I'm thinking about. So here's how I think about and how I use an ACTH stimulation test. I would pick this test when I have a dog that I say to myself, it doesn't have all of those common clinical signs. Maybe it doesn't have all of those laboratory abnormalities. It doesn't have any comorbidities, like it's not a diabetic, it's not proteinuric, doesn't have hypertension, things that oftentimes we see with Cushing's. So here's a dog you see laying here on the ground on this carpet, and you look at him and you say, he's got some features of Cushing's, but maybe he's just a fat dog. So if I have a case like this where I'm not sure, the specificity is what I'm looking for in a test. And the specificity for the ACTH stim is moderately okay. Basically, what it means is that if you look at 80 to 93%, depending on the study you look at, it means it's somewhere around 10, maybe up to 20% of normal dogs that do not have Cushing's will test as if they do. They'll test falsely positive. What's the problem with that? Is that, again, if you will go ahead and consider treating dogs that are false positives. And as we all know, treatment can cause adrenal necrosis and very serious side effects, even death. So I want to pick a test that has higher specificity so that I can reduce those false positives. I don't want to overtreat normal dogs. This dog, I'm not sure, doesn't have all the signs. Now, again, the sensitivity is a bit lower for this test, especially depending on whether you have it in the brain or even worse, if it's in the adrenal gland. 20 to 40% of Cushingoid dogs will test falsely negative for ACTH stims. Well, what's the importance of that? You know, if you miss the diagnosis the first time and they're relatively mild like this dog, they're probably not going to die of Cushing's disease, and you have time. Their symptoms will continue. They may progress, but you have time then to make a diagnosis down the road. So the ACTH stim is in dogs that I'm not sure. I don't want to overtreat normal dogs and put them at risk. And if they do have it and I miss the diagnosis the first time, the dog's not going anywhere. I can always come back and get those, values at a later testing time. So what about low dose dexamethasone suppression? That's the other major screening test we look at, where we give IV dexamethasone. So in this case, a low dose, 0.01 milligram per kilogram. Make sure if you're using Dex SP, which is 3 milligrams per ml of dexamethasone versus regular dexamethasone at 2 milligrams per ml, make sure we make the appropriate adjustments in our dose. Those are in all of the formularies and so forth. In this situation, we're going to give cortisol to the body and see how this hypothalamic pituitary axis responds. So we flood the system with cortisol, dexamethasone, if you will. That should negatively feed back to the pituitary gland. And if you're normal, it should shut down ACTH production and cortisol production in that, again, that subsequent 8 hours. And you should find at 8 hours, there should be a very low amount of cortisol on your blood sample. So generally less than 2, depending on the lab, 1 to 2 micrograms per DL. The important thing to think here is this is an 8-hour test. So again, we're putting this steroid into the system, giving it 8 hours to feed back and shut the system down. We can then document that drop in serum cortisol. Now, if you put a tumor, a micro or macroadenoma in the pituitary gland, it's not going to be responsive to that negative feedback. It's not going to shut down ACTH production. It's going to continue to excessively produce that hormone. Thus, our cortisol will continue to be produced. And at 8 hours, we're going to have a value that's above the laboratory range, again, depending on the lab, of 1 to 2 micrograms per DL. And the same thing with adrenal tumors. They won't respond to that increase in serum cortisol or serum dexamethasone. They're going to continue to produce cortisol. And at 8 hours, we're going to still have, again, that elevation, that lack of suppression, if you will, of serum cortisol. Now, generally for this test, we would run a baseline sample, 4-hour sample, and 8-hour sample. But what's important here is, again, looking at that 8-hour sample initially. That's the time frame you're going to either make a normal diagnosis or you're going to deem that patient to be Cushingoid. Again, better sensitivity here, less false negatives, and the specificity, unfortunately, drops dramatically. So this is very, very different than the ACTH stimulation test, depending on what we're looking to find. It may, in fact, we'll see in a couple minutes, discriminate pituitary versus adrenal hyperadrenocorticism. Again, it takes 3 cortisol submissions. Again, dexamethasone readily available and inexpensive. So from that standpoint, it's still not a cheap test. It's a labor-intensive test. You've got to do 3 blood samples over those 8 hours. Now, who would I do a low-dose dexamethasone suppression test on? I would prioritize this for the dogs you're pretty certain have Cushing's. They have a lot or all of those major clinical signs. They have the laboratory abnormalities that fit that clinical picture. Maybe they have some of those comorbidities. They're proteinuria, they're hypertensive many times. They can even be diabetic. And these are patients that if we don't get them on treatment soon, they're going to continue to deteriorate and be a problem. I don't have the time to wait to see what happens over time like I did in that previous less affected patient. So in this case, again, the sensitivity 85 to 100%, depending on the study. So very few dogs that actually have Cushing's will test negative. So you're going to correctly identify the patients that have the disease. And once we do that, we can start treatment because these guys need treatment now. The specificity for this test is much lower than the ACTH stim. So there's going to be a lot of false positives. So again, if you're not certain that patient has Cushing's, be careful. But again, most of these patients clinically, the picture fits, the sensitivity fits. These are patients we're going to come on because of that high 8-hour sample. And we're going to go ahead and get them on treatment as soon as we can. So hopefully that makes sense to you on how at least I look at which test do I pick. If you aren't that involved, ACTH stim, I don't want to overdiagnose you. If you're significantly involved and I think you have Cushing's, I'm going to do the low-dose dexamethasone suppression because the high sensitivity means I'm going to, again, be able to identify the patients that have the disease, not having false negatives, and I can treat you. Okay, so let's take a look at a summary for what we've learned so far, guys. What tests do we do to say if you have Cushing's if you're a dog? Serum cortisol, urine cortisol creatinine ratios, inexpensive, but again, they just don't give us the information that we really need to see. ACTH stims and low-dose dexes, even though they've been out there now for over 50 years, they're expensive. Again, many times they'll get the information we want, especially if we prioritize which test to pick. But again, they're not always easy because we don't have access to ACTH for many of us. We still have labor-intensive tests where we're doing multiple samples over time on the day that we're doing testing. All right, so that answers question number 1. Does the patient have Cushing's? If I have an abnormal ACTH stim or I have an abnormal low-dose dexamethasone suppression, the answer then is hopefully yes, they do. And of course, we would then say question number 2, which type do they have? Is it ACTH dependent coming from the pituitary gland, or is it ACTH independent, meaning that they have an adrenal tumor? So we've got 4 tests we could look at here to try to differentiate patients that have Cushing's into which type they have, which would be important from a treatment aspect and maybe even a prognosis aspect if you have significantly aggressive adrenal tumors. So we've got the high-dose dex suppression. We'll revisit the low dose for a second. We have imaging of the adrenal glands, and we have the endogenous ACTH level, which is what I wanted to introduce to you guys tonight. High-dose dexamethasone suppression, let's not waste a lot of time talking about it. The theory is we give a higher dose of dexamethasone, and if you had a pituitary tumor, you're more likely to be able to suppress that. If you have a tumor in your adrenal gland, you're less likely to suppress that. So basically, you would see PDH or pituitary cases that are ACTH dependent should suppress less than 1 to 2 micrograms per DL. Patient with an adrenal tumor should not suppress. They would remain at 8 hours above, again, 2 micrograms per DL. Does the test work? Guys, be honest with you, 50% of pituitary dependent patients do not suppress like they're supposed to. So it's a situation where it's really difficult to use this test with certainty that you're going to be able to distinguish who has a pituitary tumor or who has a adrenal tumor based just on this test. It's like flipping a coin. So to me, I don't find much value in clinical practice running this test. Let's go back to the low dose dexamethasone suppression. So maybe already did that test. This is where the 4-hour cortisol level becomes important. We said the 8-hour cortisol tells you if you have Cushing's disease or not. So take a look at this patient here. Here we give a look at cortisol level on your y-axis and hours after giving dexamethasone on the x-axis. At the basal level, before you start the test, this patient has a cortisol level. These are in nanomoles per liter of 100. We go ahead and we give dexamethasone. We look at that 8-hour mark, and that patient has not suppressed below, in this case, 30 nanomoles per liter. So that patient is Cushingoid. That's what diagnoses Cushing's. But at the 4-hour mark, this patient did suppress below the norm. And that generally should tell us in almost every case, that's a situation of pituitary dependent disease. That's called escaping from suppression. It's a common pattern that we're looking for. You might also see two other patterns. The second one is called a partial suppression. So again, the patient starts off at baseline. At 8 hours, that's the first thing I look at. They're above 2, or in this case, 30 nanomoles per liter. That patient is Cushingoid. Now, what else can I say? This patient went down at 4 hours. It was more than 50% suppression from the baseline value. And when that happens, that again is suggestive in almost every case of pituitary dependent disease. Last pattern we're looking for is also a partial suppression. This is a situation where, again, we start with our 0-hour cortisol. We go out and look at our 8-hour. Again, it's high. Patient's Cushingoid, but the patient did not suppress 50% at 4 hours. It was less than 50% suppression, but it did suppress by more than 50% between the baseline and the 8-hour cortisol. So that's another form of partial suppression. And because of that degree of suppression, these are going to be deemed patients with pituitary dependent disease. So those are patients we can move on to your therapy of choice, Trilostin, Lysidren, whatever you're going to use. All right, third thing we can do is look at the adrenal glands themselves with ultrasound, because ultrasound is available either in our practices or by referral for most patients. I always, when we're teaching ultrasound, I always ask the students or the veterinarians, do you see the adrenal gland? Do you see the adrenal gland? And again, it's a hard gland sometimes to recognize until you get some experience. But what I always tell them is you may not see it, but the adrenal glands see you. You guys know they can actually look up those transducers. They can actually see you at the machine scanning. They can actually see you. But if you get better at it, you do more of them, and you will be able to see them. So remember that if you have pituitary dependent or ACTH dependent disease, you're going to get a big bilateral enlargement because both glands are equally being affected. You're causing corticotropin growth in the cortex. Cortisol secreting cells are getting bigger, so the gland should get bigger. And again, what we do is we simply look to find both the right and the left gland. They look pretty darn similar. They're hypoechoic. Once you get used to finding them based on landmarks, they're pretty easy to find. And again, if they are symmetrical, which these ones are, and they are thicker than normal on their cortice measurements, that would be the case that would say this is bilateral adrenomegaly. And again, that would be consistent with ACTH dependent or pituitary dependent disease. So a good test by itself, you can't use this to screen just for Cushing's disease. You have to go ahead and have it in the context of, I already know the patient's Cushingoid. Now, what do the adrenal glands show me? Are they bilaterally involved? Or, like in this guy, is there a big tumor coming out of the cranial pole of this adrenal gland? And that, of course, would be ADH or ACTH independent. That's an adrenal tumor. Again, there's a lot of experience necessary. And until you get that experience, sensitivity and specificity can vary widely. And again, it's also availability. If you're not confident in doing these exams, you've got to send them out to somebody that does. And sometimes that can be weeks or months, I hear, to get referrals currently. Like crazy stuff. But again, this is a great test. And with not that much experience, just being dedicated to finding these guys, trust me, you guys can do it in practice. And you can go ahead, and there's no license or you're not going to go to jail if you're looking for adrenal glands. You can do it. It doesn't take a specialist to do this exam, but it is expensive. You got to have the equipment and the training time. So the last test, then, that's probably new to some of you guys, is what about using ACTH, endogenous ACTH produced by the pituitary gland, as a way to differentiate whether a patient has Cushing's or not. So in this situation, what you could do is you could certainly do your normal ACTH stim or your low dose DEX, as you see here. And again, at 8 hours, if they are either overly stimulating or not suppressing, then you've made your diagnosis of Cushing's disease. But when you drew that initial sample, go ahead and draw a plasma sample and put it in your refrigerator. And then if you can determine that they have, in that 8-hour period, you've got to be able to do this test in your hospital and not send it out. But if you can do that ACTH stim 1 hour later in your clinic or 8 hours later, and it's positive for Cushing's disease, you go back to your refrigerator, you take that plasma sample out, and you determine the endogenous ACTH level. And that's going to help determine, again, is the problem in the brain or in the adrenal gland. If your cortisol level supports Cushing's disease, you go to the fridge, do your ACTH level. If it's greater than 80 picograms per ml, it's considered an excess value. That right away tells you the pituitary gland is responsible for this. It's making too much ACTH, and that again is ACTH dependent or pituitary dependent Cushing's disease. I just did this in my hospital if I could. If I drew that sample and it was actually low, what that would suggest is that there may be a tumor in the adrenal gland that's secreting so much cortisol, it's negatively feeding back and shutting down ACTH production. So there's no tumor up here in this situation. This is ACTH independent Cushing's disease or an adrenal tumor. And again, usually those patients have an ACTH endogenous level less than 10 picograms per ml. So why don't you guys do that more? Why don't we do this in private practice? Well, I'll be honest, I didn't do this in private practice. In the university setting, we can do it because we have a big Imulite chemistry machine right down the hallway, and it can run plasma ACTH levels. We've not really had the capability of doing them in our practices because if you remember, this endogenous molecule, this EACTH molecule is very labile. It degrades very quickly. If you package it up and send it even on ice to a laboratory, you're losing hormone activity quickly. And generally within the time it gets to the lab, you may see a falsely low value from degradation of the hormone. So again, it was labor intensive to collect it, to package it, to send it appropriately. And unfortunately, there was only limited laboratories that would run the test. So even though we may have learned about this in vet school, we weren't doing it in clinical practice, let's be honest. But what if I told you now could? And that's going to be something that our sponsor tonight is going to have for us as we come up in a couple minutes. We could then actually draw that level in our own clinics and run the sample before it degrades and hopefully get ourselves an accurate ACTH blood level. Okay, so summary, guys, real quick. High-dose dexamethasone suppression test. I wouldn't run them. Again, it's not going to give me reliable information that I want. If I've done a low-dose dex, be sure you go back and look for one of those 3 patterns, those suppression patterns that would tell you that it's unlikely that you have an adrenal tumor and the problem's in your brain. You can go ahead and move into medical therapy in those cases. Again, if you refer or you can do ultrasound in your practice, that will also help you in diagnosing which form of Cushing's you have just based on the physical characteristics of the adrenal glands. Again, expensive tests. What if we did endogenous ACTH in our own clinics? Cuts the cost down considerably in this differentiation. And again, it's a simple thing to run with a cartridge type analyzer in your own practices. Okay, so that's Cushing's disease. We'll come back at the end and summarize that one more time. That's a review of traditional tests, when to maybe consider ACTH versus low-dose dex, which tests that I'm not as excited to use, and then also to try to get you a little bit pumped up and excited about maybe considering doing endogenous ACTHs. Let's move then and talk about the use of testing for hypoadrenocorticism, Addison's disease. You guys probably all know this breed over to your left, pretty easy, standard poodles, a whole different variety of colors there going on. Hopefully some of you know the breed of dogs over here, Nova Scotia duck-toling retrievers. I owned one, Kaylee, for, 12 years or so. She was not an Addisonian, but both of these families of dogs, these breeds, are genetically predisposed to Addison's disease. Everybody wants to breed their dogs to standard poodles and make all these crazy Bernedoodles and other types of doodles nowadays, Labradoodles. What if you bred these two dogs together? What are you going to get? Number one, you're going to get a lot of Addison's disease, but you're also going to get this cute little puppy, and that is now referred to as a duck doodle. So there you go. Nova Scotia duck tollers and standard poodles. Okay, so we don't have a consensus paper yet on Addison's disease, although one is coming from the ACVIM. Again, you don't see as many Addisons as you do Cushingoid patients, but it's still a disease that's out there. It's gotten a tremendous amount of attention in the last decade. Remember, there's two types: primary hypoadrenocorticism, where we basically wipe out the zona fasciculata, where cortisol is made. When this happens, it's usually a physical destruction of the adrenal gland, especially the cortical tissues. Either immune mediated is the most common. It's probably why we see it as a genetic thing in certain families, just like we see with thyroiditis. It rarely can be caused by cancer or infection, and again, rarely by vascular infarction if you infarct both glands. If you only wipe out the zona fasciculata, where we make cortisol in the schematic up here to your upper right, then you're only going to be cortisol deficient, and that's considered atypical Addison's disease or atypical hypoadrenocorticism, whereas glucocorticoid deficiency only. Your clinical signs will reflect the importance of what cortisol does to the body. If we wipe out the entire cortex, we wipe out that zona reticulosum as well, that's going to be where aldosterone is produced. And again, when that happens, we get those crazy sodium, potassium, and water imbalances. And we see both the destruction or the insufficiency of steroids, glucocorticoids, and mineralocorticoids. We'll call that typical. So again, signs are going to reflect both lack of glucocorticoids and lack of aldosterone to regulate water balance and electrolytes. You can rarely, and again, I can't stress this, naturally occurring secondary hypoadrenocorticism is quite rare. This would be where the pituitary gland itself physically is damaged or destroyed and cannot make enough ACTH to maintain normal steroid levels. Again, in this situation, because it's only wiping out ACTH production, this would generally really only affect the zona fasciculata, and we'd see isolated or atypical Addison's disease, where we're only deficient in glucocorticoids. Again, you can get pituitary tumors rarely, head trauma. There can be some congenital defects that can create pituitary abnormalities, but not a real common disease to see. Where we actually see it the most is in patients that are taking steroids, either orally, topically, injectably, where the effect of the cortisol in the bloodstream will negatively feed back and lower ACTH. And then we abruptly take those steroids away, and the patient can't make cortisol, can't make ACTH right away. So that would be iatrogenic secondary hypoadrenocorticism. Okay, so again, with Addison's disease, two questions. Is the patient Addisonian? And if so, if they are atypical, where they're only lacking glucocorticoids and their mineralocorticoid levels are normal, will that eventually progress to become typical? It'd be interesting or nice to know if that was going to happen. So again, just like we said before, we want to test patients that have common signs. It's a little more difficult to do with Addison's disease. If they're typical and they've lost both hormones, they come in pretty sick, right? There could be acutely hypovolemic, shocky, sudden onset disease, and many of them have GI bleeding. And again, they get significant deviations from the norm of their electrolytes, hyponatremia, hypokalemia, typical Addison's disease. Most of us hopefully can recognize that. It can sometimes be confused with acute kidney injury and acute kidney failure. But if you can rule that out, Addison's disease is definitely going to be top of the list differentially. Now, if you only are missing your glucocorticoids, those signs can be very nonspecific. You're going to have normal electrolytes, and really the biggest impact will just be on energy and the intestinal tract. So you have patients that are somewhat lethargic, up and down. Maybe they eat some days, they don't some days. They can get some vomiting or diarrhea, but it may not be real consistent in the beginning, and it can be confused with any other primary GI disorder. So anytime you have a GI disorder that's waxing and waning, you're struggling to make a diagnosis, think Addison's disease, atypical. That may very well be what you're dealing with, and they should be tested for that. Okay, so what's the gold standard? The ACTH stimulation test. Again, we can go ahead in a normal dog and stimulate their adrenal glands with ACTH. If they don't have any cortical tissue left, or they can't produce ACTH, then they're not going to respond. They're going to have a baseline at 0 hour and a 1 hour post that don't stimulate. Basically, your values are generally less than 2 micrograms per DL, and oftentimes they're non-detectable. Again, we said the same things. It's an expensive test. Many times we don't have cortisone. These cases always come in the middle of the night, weekends when internal medicine's out of the building, and certainly can make it a challenge sometimes to do it. But if you have access to ACTH, this is the test of choice to get that baseline and that 1 hour post showing basically very low levels and no ability to stimulate, no reserve cortisol ability to produce. One of the problems, again, is it doesn't help us delay. We can delay treatment if we don't have that access, so we have to wait for it. We don't want to delay treatment in dogs that are obviously shocky and critically ill. And it doesn't discriminate between atypical cases if they're primary or rarely secondary. So if you don't have access to it, is there anything else we could do? So again, we mentioned basal cortisols of not really much value for Cushing's disease. Here, there may be some value, though, just looking at a basal cortisol level. Again, we would expect it to be very low for Addison's dogs, less than 2 micrograms per DL. But by itself, that is not able to make the diagnosis of Cushing's. Why is that? Even if we destroy that gland and it can't produce cortisol, if you look statistically, Dr. Lennon's study back in 2007 showed very demonstratively that if you are an Addison's dog, almost every single patient is actually below 1 microgram per kilogram, 1 microgram per DL on this testing, where patients that are sick for other reasons sort of cross over. And while most of them have normal or high cortisols, there's definitely a subset that will have low cortisol levels. So we really can't distinguish when the level is low on a basal sample. Who are they? Are they Addisonians or are they not? And again, that's going to be one of the problems with poor specificity. But notice there's an area up here where there's nobody sitting up in this quadrant. So again, if you look at that quadrant up there, these are Addisonians, and you don't see anybody that's really Addisonian and has a normal cortisol. So this is a 99% sensitive test, meaning that only 1% of dogs with Addison's would be expected to have a cortisol above 2. So this test, while it can't confirm Addison's disease, if you have a normal cortisol level above 2, then statistically you do not have Addison's disease. You can hopefully rule it out and move on to other testing to figure out what that patient has. So again, while basal cortisol doesn't make the diagnosis, it can help us rule it out if we don't have access or the ability to do an ACTH stimulation test. We mentioned urine cortisol creatinine ratios before. There's been a couple of recent smaller studies looking at whether this ratio could help us in diagnosing or ruling out Addison's disease. And different tests and different studies use different methodologies. And basically, it was reasonable that if you had very, very low levels of cortisol in your urine, that you certainly may be able to increase the suspicion of Addison's. And if you had relatively normal levels of steroid cortisol within your urine, it had very good negative predictive value, again, to rule the disease out. If you do this test, you have to take a good look at what lab you use, what methodology they use, what their laboratory reference ranges are. Again, I would like to see a little bit more information come out, larger case studies or prospective studies looking at the ability of this test to clearly differentiate these patients. But it's an interesting thing. And if you didn't have any access for some reason to blood testing, you certainly could consider trying to use urine cortisol creatinine ratios to rule the disease out or increase the sensitivity to that. Excuse me for a second. Somehow I just knocked off my thing. Let's not increase. It wants to update all my stuff here. Let's get back to where we were, guys. Sorry about that. All right. So what about using endogenous ACTH in Addison's patients? So you suspect a patient has Addison's disease, what if I looked at both cortisol, which I would expect to be low, less than 2 micrograms per DL, and what if I looked at my ACTH? Because in an Addisonian, a primary Addisonian, there should be the desire to make cortisol. The brain should be pumping out ACTH. So if that was the case, could that help us? So we already said that a cortisol level by itself cannot diagnose Addison's disease because of this overlap. If we looked at endogenous ACTH levels only, again, unfortunately, there's an overlap between healthy dogs, Addison's dogs, which statistically do have higher ACTHs, and dogs with non-adrenal illnesses. So by themselves, neither of these two tests, cortisol or ACTH, can make the diagnosis for us. But in every veterinary school and in life, they have these wonderful people called statisticians that can design tests and get more information out of things than we do as clinicians. And there was 2 nice studies in the mid 2014-15 range, different universities looking at this problem. And they came up with the fact that what if you took the cortisol level, which should be low, and the ACTH level, that in most cases, primary dogs should be high, and did a ratio, a cortisol to ACTH ratio, or the CAR ratio. If you did that and then teased out the numbers, there's a clear differentiation between dogs with Addison's disease that are going to have very low CAR levels, in these studies less than 0.01, and patients that either are normal dogs or non-adrenal illnesses that will be basically above 0.03. So the numbers in these studies was very good. Sensitivity, 99%, specificity, 100% in diagnosed primary hypoadrenocorticism based on these low CAR levels. So again, if you had the ability in your practice to do cortisol and endogenous ACTH, you can calculate this ratio. And again, if you didn't have access to ACTH exogenously for stimulation, you could go ahead and use this as an alternative testing method to hopefully make this diagnosis of primary hypoadrenocorticism. If your ACTH was very, very low in that testing and your cortisol was very, very low, then in theory, that would be a secondary hypoadrenocorticism case or a laboratory error. Again, this is a labile hormone. If something went wrong in the testing, then this could be a lab error. We just don't see that many secondary cases. Okay, so guys, here's the wrap up for what we're going to talk about tonight. Again, I'd like you to consider the fact that you now can do this sort of testing with looking at both cortisol and also looking at pituitary levels of endogenous ACTH, what it's producing, to help you determine whether a patient has Cushing's or Addison's. Maybe much simpler than some of the testing we've done over the decades. There's several machines currently on the market that run cortisol levels, but TRUFORMA, made by Zomedica, our sponsor tonight, is the only machine currently that can do endogenous ACTH and cortisol on the same machine. Again, serum for cortisol, plasma level, or plasma sample for ACTH. This is a unique type of testing. It's called bulk acoustic wave senses. And basically you have nothing that has to do with fluorescence, nothing that is influenced by lipemia or hemolysis. This is a sample that you basically put a blood in on a machine that has a vibrating sensor plate within it, platform that is impregnated with antibodies against the hormone that you're trying to identify and how much is there. So basically when you put these antibodies on this sensor plate, they're impregnated there, and apply electrical current to it, a signal in, it's going to vibrate at a certain frequency based on the weight. And now you put your blood sample in, your serum or your plasma, and as ACTH or cortisol flows through the sample over this resonating sensor, those antibodies will start grabbing those hormones, and that changes the weight of the sensor, and the vibration then will change depending on how much hormone's in your blood sample. So the signal that comes out, that frequency will be different, and there are algorithms then that can calculate how much hormone is in your serum or plasma sample. So it's pretty cool technology. It's in cell phones, airplanes, all kinds of different things in today's day of age. And again, it's getting away from some of the optical fluorescent type testings that we've done over the years. The nice thing is it's inexpensive, it's small, and it can be put into cell phones, into our clinics, and so forth. On the left is the TRUFORMA machine, about the size of a shoebox. It has a cartridge you can see inserted in there already. And again, you put your serum or plasma sample in, you wait 15 minutes for this to flow across the sensor, and then whatever the frequency change is will be calculated to give you a microgram per DL of what, or a nanomole per liter of what hormone you have in your sample. Pretty cool. So does it work? Zomedica has done some nice white papers showing that with the TRUFORMA machine and looking at cortisol levels and ACTH levels, that it is very well correlated with the standard machine in veterinary medicine for diagnostics called the Imulite 2000, made by Siemens. But again, white papers and things that go on in companies, you should always want to see independent validations. These are just your cortisol and ACTH correlation curves that were done at Zomedica. A nice paper came out this year at ACVIM from Tennessee. And bottom line is they did show that the analytic performance in an independent study looking at cortisol was in fact good, and there was high correlation with no apparent biases. There's also a nice paper, an abstract, a poster actually, at ACVIM, again, independent, from the University of Georgia, showing the use of the TRUFORMA machine in diagnosing Cushing's disease by using the low-dose dexamethasone suppression test. So again, I would call your interest that these are papers that, again, are data collected, not necessarily being done at the company. And it's good to see that we're doing things. Mark Peterson has been involved with this machine on the feline side, looking at TSH levels, and his results have been very supportive that this bulk acoustic wave technology, again, is a good solid technology for our use in our clinics. So let's get two more slides and then we'll take questions. So let's take a look again and summarize what we mentioned about hyperadrenocorticism or Cushing's. So this is maybe an alternative to what you've been doing for years in your diagnosis and differentiation of Cushing's patients. So again, you take a patient that you have compatible clinical signs, things fit that this patient could have Cushing's disease, or you're pretty darn sure they do. So what you do, you bring that patient in, you draw a plasma sample. That's going to be useful for ACTH determination. You put it in your refrigerator, refrigerate it immediately. You go ahead then and you do either your ACTH stim or your low-dose dexamethasone. I have 2-hour sample. It should be 1-hour sample there. Low-dose dex, of course, would be an 8-hour sample. And if you find in that screening test, because you can run these in-house, if you are able to confirm Cushing's disease, because your ACTH stim or your low-dose dex is inappropriately elevated cortisol levels, you've confirmed Cushing's, you then go back to your refrigerator, take out that plasma sample, run it through the TRUFORMA. If it's elevated, that's ACTH dependent, that's a pituitary dependent tumor, we're going to treat that patient medically. If that sample is low, your ACTH is below baseline, then certainly that would be highly suggestive that this patient is not producing ACTH from the brain. This is ACTH independent, and that would suggest there's a tumor in usually one or both adrenal glands. And that patient should be followed up with imaging to see if in fact you can confirm that. And that patient might benefit from either medical or surgical therapy. And again, the prognosis may be very much different than a patient with pituitary disease. So again, a very different way you could do it all in one day in your clinic with these two sort of samples. If you think you have a patient with Addison's disease, patient has consistent clinical signs, laboratory abnormalities, whether they're typical or atypical in presentation, you draw both a baseline serum cortisol and a plasma ACTH level. You go ahead and run the serum cortisol first. If it's below 2, highly suggestive of Addison's disease. We go ahead and take that ACTH level in plasma, plug it into the machine, and then we can see what our result is. If our result is elevated, then we do that CAR ratio calculation. If it is less than 0.01 ratio, that is a patient with primary hypoadrenocorticism. You just made the diagnosis of Addison's without having to do an ACTH stimulation test. And then if that ACTH level is low, you don't do the CAR ratio, you just sit back and say, this suggests the patient has a lack of ACTH production, a lack of stimulation of the adrenal glands, that would be a secondary hypoadrenocorticism case. And again, start saying, hey, has this patient been receiving steroids? Has it had head trauma? Is there anything that would suggest there was pituitary disease? So guys, to finalize, hey, traditional testing is great. 50 years of the ACTH stim, low dose DEX, and then going into differentiation testing. But again, the new era is here. There's things we can now do in our own clinics. This new type of bulk acoustic wave testing with the TRUFORMA machine, gives you the ability to do some things right there. And it's cool. It actually has a Bluetooth capability where during that 15 minutes you're waiting for results, you can be playing your favorite country music for me. It's cost effective. I can let TRUFORMA and Zomedica tell you about prices, but very, very competitive compared to any outside laboratories. Again, both in-house white papers and the onset of independent testing tells us it's reliable. And again, it's a point of care diagnostic that you can include in your own clinic. Now, it doesn't just do ACTH or cortisol. You can see, again, it's in-clinic use, no reagents, sealed cartridges, no mess to be made. Again, bulk acoustic wave technology, been validated against the state-of-the-art Imulite 2000. You can do cortisol, you can do ACTH, not only canine, but recently it's also been developed now. If you were a mixed animal practitioner or a equine practitioner, you can look at equine Cushing's disease. It can also run total T4s, dogs and cats. It can do free T4s, dogs and cats. It can also do TSH levels, both in canine, and it's also been optimized. That's part of what Mark Peterson reported, so that we can measure very, very low levels of feline TSH that would be important in iatrogenic hypothyroidism after treatment. So this machine has a lot of available things it can do, and even more are coming. BNPs, I'm sure, and other types of hormone tests